Use. Morning, everyone. So I am going to present ECG conference, and it's about our ECG conference. This is ECG we will talk about today. What UG? Go. There's no progress typically because it's going to obviously better and the differential is white and also if we are shown all are weak. Also, deep as better than implicit.
Regular rhythm, and I see the one-to-one looks like one-to-one conduction. After the QRS, looks like retrograde P wave, and RBB morphology. So I think I didn't see any AV dissociation and fusion beat after this. So I think HTT with appearance maybe. I agree with almost.
Regular LOQRS tachycardia was already said. This RBB pattern and the axis is you'll find maybe dissociation. You can see the EBS wave in inferior wave and RBB pattern with the LOQRS tachycardia. So it could be a vascular wave or can be the VT with the BB morphology.
Okay, so this is a regular tachycardia. It's blood complex rates of probably about 150 beats per minute. It's difficult to see clear P waves. There's an extreme axis deviation, but there are some possible, I'm not sure if these here possibly P waves, but their relation to the QRS I think varies a bit, and their amplitude also varies. So a possible dissociation, and then even though it's broad complex, the intrinsicoid deflection is very sharp, which suggests that it's using the conduction system. So my main differential would be a fascicular VT, but I'd also consider an SVT with aberrancy, though that is less likely because of the AV dissociation. Yes. Thank you.
How's the day? Good morning. Good morning.
And you want to talk about this? Can you guys hear me?
Yes.
Yes.
Okay. So you do have clearly right on the principle tachycardia. Now someone says about the AV dissociation. What is the definition of AV dissociation? We need to know that clearly first. You have a one QRS, one P wave, every single complex? Yes or no? Yes, there is one-to-one conduction, one-to-one correlation. Okay.
Yeah.
Now, correlation between A and V time maybe changed a little bit, but you couldn't say there's a dissociation here. So there is certainly A and V timing can change, it can vary a little bit. Okay. So someone pointed out already V3 had some little bit of a change in relationship to the second notching to the front QRS complex. Very little bit. Okay. But I can see every complex has a one P wave. So this is not a dissociation. You cannot call that. So you need to be careful. So whenever there is one QRS, one P wave, there's no, you cannot state that a dissociation. Now, there is maybe V to A timing maybe change a little bit. Then you need to think if P wave following QRS come closer to the QRS complex, is the tachycardia cycle length change? Yes or no? That's something that you need to look for. Does or does not? The cycle length is very stable, doesn't change, right? Correct? Yes or no?
Yeah.
Yes. So that means possibly, maybe ventricle driving A, not the A driving ventricle. Make sense?
Mhm.
Okay. Now, what do you think about the V5, V6 S wave? Do you normally see such a deep S wave in aberrancy? Right under aberrancy?
No.
No, you don't. So this is somewhat suggestive of somebody says already, most likely vesicular VT. But it's hard to know. If you look at the lead one, take a look at the lead one, there's a little bit of a variation of a baseline. But my eye, number 4 complex looks to be wider than the rest of it. Can you see? That guy. Yeah, you just passed. No, before that. Yeah, that one. Preceding ones had a taller R wave. This one has a smaller R wave. Can you see it? And
Yeah.
QRS duration slightly wider. Agree? Because next subsequent second, third, or fifth bit also has a taller R wave than that guy. Right? So R wave grow right there. So that suggests you what? This is because if you look at the lead 2, that particular bit is wider. Yeah, that one is wider than other. Okay? So what does that mean? SBT can do that, yes or no? SBC should not do that unless you have a rate variation, okay? If this is aberrancy. So this is against something against also aberrancy, okay? I'm just pointing out a few things here. So I think I agree that someone already told you, most likely ventricular tachycardia with the 1-to-1 VA conduction time variation a little bit, but a narrow complex in nature and EKG morphology highly suggestive of posterior fascicular VT. Differential diagnosis is what? Papillary muscle VT, posterior papillary muscle VT. And then last would be possibly, you can have a double tachycardia. In other words, can you have a AVNRT, for example, with the fascicular VT simultaneously? Answer is yes. That's another differential. The last would be SBT with the aberrancy. Okay? Any other comment for you guys? Anybody want to say anything else? Okay, you want to go to the next slide? Let's take a look. Okay, so if you convert to sinus rhythm, question is how did you convert to sinus rhythm? What did you guys do? Do you know? They give a medication, cardioversion. What do they do?
In emergency room, they try
Cardioversion. Okay. But again,
cardioversion.
let's go back. Okay, let's go back to your question then. They give even amiodarone. Okay. Now, if you are emergency physician or you exceed in this patient emergency room, what would you done differently? Anything different? Would you consider giving IV verapamil to this patient, for example, if you thought that this is a fascicular VT? Right? That's something that you should do probably first before you cardivert, unless patient is very unstable hemodynamically, hypotensive, and the patient in the shop. Of course, you're not going to wait. But then if your patient is awake, talking, have a reasonable blood pressure, you may want to give perhaps a 5 milligram IV verapamil, because that can be what? Give you a differential diagnosis between fascicular VT, papillary muscle VT. Because if your ventricular tachycardia rate slow down or terminate, favor for fascicular VT. Okay? All right, let's go. Anything abnormal in sinus rhythm here? Anyone want to read it? Any question? Josiah? No?
Good morning, Dr.
All right. Okay. Okay, go ahead.
This is the case of the 54-year-old
Mhm.
who has a palpitation and shortness of breathing after drinking, and he has underwent clear muscle VT ablation
Okay.
12 weeks ago. Also, he have a hypertension.
Mhm. Okay.
Then the echo shows normal, and also coronary angiography showed there is no significant stenosis around the vessels, and the chest X-ray shows well. And in the emergency room, it was outside of the other hospital. They tried cardioversion 2 times, but it was failed. And then they tried emitron infusion. It cannot terminate the tachycardia. After that, they used the adenosine, but it was not terminate tachycardia. After that, they tried the verapamil 5 milligram, and it was cannot terminate. At the total of the 50 milligram was successfully terminated tachycardia.
Okay. Now there's a catch here. If you given patient verapamil intravenously, how long do you wait? Do you have any idea? So I would be curious to know what was the time interval between the first dose and second dose of verapamil. So if you give a verapamil, what is the IV verapamil? And we're gonna take a pick blood sample level. Do you know pharmacodynamics? It's not adenosine, as we all know that. So you're gonna have to wait a little bit. The question is, how long do you wait? That's a practical question I'm asking. Do you know exactly how long did they wait between the 5 milligram after that 15 milligram? No. The reason I ask that question is the following. If you gave adenosine 18 milligram before the verapamil, think about what's the pharmacology they're going to do. Adenosine will drop the blood pressure, will increase the extreme high level of catecholamine surge post-adenosine. That was the maybe reason why the verapamil will not be effective 5 milligram. Okay? So you need to start understanding pharmacodynamic of these people. And usually if you give adenosine bolus high doses, you want to make sure that the patient come back down to the baseline rate before they're pushing the verapamil. Then usually we give an interval of 5 to 10 minutes each bolus. Okay? Okay. So what do they do after that?
After that, Chinese rate mass conversion. And then
Yeah, what?
yeah,
What did you do after that? Did you do procedure on him, or did you just treat him medically? What was the management?
yes, next week the patient is scheduled next week for ablation.
Okay. So you're planning to do ablation.
Yes, next week.
Now let me ask this question. Previous posterior papillary muscle VT diagnosis, is it correct?
Yes.
Or you think it's incorrect? Is there any relationship with the posterior papillary muscle VT ablation, this VT? Where the ablation was done? At the Yonsei University?
No, other hospital.
Which hospital is this?
I guess some. Yes, 12 years ago, he out ablation.
So you may try to get a EP study result from them to review it, okay? Make sure that the 12 of the EKG is the same or they are different, for example. Okay? So I think it is something important here. And then other characteristic of a VT that you guys forgot to mention is patient has a small Q, the V1, less than 40 millisecond, and then initial R wave is tall. So there's a QRSR. So basically, your first notch is taller than second. So that's another favor for VT. Okay. Anyway, so you're going to ablation next week?
Yes, next week.
Okay. And good luck with that. I hope you plan well the procedure.
Good morning, Dr. Hong.
Yes, sir. Good morning.
Can you hear me?
Yes, I can certainly hear you, sir.
Okay. May I ask you one question? Yeah, so you said that when we give verapamil to the patient, we can differentiate between papillary muscle and fascicular. So what is the response we can see during the verapamil injection for the papillary muscle? It stopped
No.
immediately, not unlike the fascicular VT?
No. If patient has fascicular VT originating near the papillary muscle, will behave the same, except that in our experience, the response is a little lesser likely convert. And then if you have a pure fascicular VT, non-closed papillary muscle, they easily slow down and response is quicker. That's what we found. In other words, sensitivity may tell you, and papillary muscle very unlikely terminated by verapamil. And then also QRS complex is not papillary muscle, if you look at it. right? Only the question I have, remember I just mentioned number of 4 complex is a little bit wider than other.
Yeah.
That suggests that maybe this is something that has a different local exit site differences because of previous ablation, or this is just the fusion bit between 2 different complex. I cannot tell you, but they're going to be looking pretty close. But if you look at the lead one array with the image shorter, smaller, that means more inferiorly coming from the laterally. That suggests that maybe this is a more closer papillary muscle exit site. But I think it's a fascicular VT, maybe has an exit site from the first fascicle as well to the closer papillary muscle. That's what I think. Maybe that one might be the differential diagnosis they missed, and that they ablated posterior papillary muscle area. Okay.
Okay.
Yeah,
So
but
I have
curious, I'm curious and interested to know what they're gonna play next week. They can tell us what is update about this. Okay.
I have 2 or 3 patients that was admitted that have nearly the same morphology of the QS.
Mm-hmm.
So when I give the verapamil injections, it's
Mm.
slow down,
Mm-hmm. Yes.
and then there is a sinus alternated with the VT like a competitive rhythm,
Right.
and then it stopped completely. So this type of response is most likely a fascicular VT, right?
Gravity. Yes, correct.
So
So
it cannot be a papillary muscle, even
no.
though the QS is more
Right. Right.
wide than this.
Yes. Very unlikely. Okay.
Okay.
Yeah. Because the confusion being at the fascicular VTs, they're not coming from the fascicle. A lot of people think it's coming from fascicle. No, it's coming from the subtotal Purkinje fibers near the fascicle. Whether this is a micro reentry, macro reentry, a lot of debate about it. I personally, when we mapped with the 3D mapping, as far as we can tell during the procedure, most of them appears to be focal reentry or focal tachycardia. The other hand, there is indeed a macro-oriented tachycardia involving fascicles, but those ones are tended to be associated more structural heart disease patients, post-MI, dilated cardiomyopathy, so on. Those are you can truly entrain anywhere from the fascicle. You can entrain anywhere. Those are the suggestive of macro-oriented tachycardia. That's what Nogami, I think he had a couple of papers on that. But in most other cases that see such a young man without any health problem, we found that many patients we ablate from the Myanmar, some other area, even your country, Cambodia, looks like a circuit is very discrete, small. That's why you can ablate, several times and you can get rid of it. So I think it is all, suggestion, but that does not involve huge circuit. Okay. And then also after your ablation, you don't develop posterior fascicular block, neither the anterior fascicular block. These people.
Dr. Wang,
Yes, sir.
this is Sanjin Park. So I have a question about verapamil sensitivity.
Yes.
When you give verapamil, if
Yes.
the VT slows down a little bit, let's say
Yes.
like 150 to let's say like 120,
Yes.
can that be considered verapamil sensitive?
Oh, that's a positive response. That's a verapamil sensitivity. Verapamil sensitivity does not mean termination. They can slow down or termination, either way. Okay.
And I have one more question. How high dose do you escalate? If it doesn't respond at 5, you should go 10. Do you go
Yes.
15? And all?
Usually more than 10 milligram is often does not give any additional effect, especially you already gave 5 milligram before, and then you're loading another 10 in the interval of 5 to 10 minutes. Verapamil is still on board. Verapamil half-life is about 30 minutes at least. Okay.
Thank you.
You just need to be patient, monitor patient carefully. Okay. Also, then another interesting I want to tell you, if you look at the tracings after verapamil, many patients will develop VA dissociation because verapamil blocks AV node. That's a further confirmation of the VT. Make sense? So often My fellows, they give a medication, they walks away, and then they call the patient emergency room. Hey, termination, no termination. They don't bother even watching what happened to the verapamil. So that's why often they miss slowing and transient VA dissociation, so on. Okay, this is something that you need to be, especially when you're in learning stage. I highly recommend once you give a drug interaction, sit tight. We look at the EGM tracings, and you enjoy it and you learn a lot more. Okay. Anything else? Almost time's up, but you got only 3 more minutes. Any other question, please comment.
No, thank you.
All right, thank you. Good job. Good luck next week.
Good morning. My name is Kofi Samoa, and I'm presenting the EGM conference for today. So this patient is a 60-year-old male who underwent radiofrequency catheter ablation 17 years ago in another hospital. We do not have the details of that catheter ablation available. However, he complained of palpitations and was referred here and was being managed on viroxaban, flecainide, and bisoprolol. When he came here, this was his resting ECG at the outpatient clinic. So here we see that in the rhythm strip, it's an irregular rhythm. And then we can see some P waves here in lead 2 upright and P waves here in lead 2. And then also here in V1. So with this ECG, given the and the PP interval is the P wave rate is about 250 thereabouts. So the differentials for this would be an atypical atrial flutter or an atrial tachycardia. Those I believe would be the leading differentials for this ECG. This is the chest X-ray that he did, which is essentially normal. And he had done an echocardiogram and cardiac CT outside the hospital, and both were also normal. So he was scheduled for an EP study, which was done on the 31st of December last year. And this is the initial catheter positioning with the decanav catheter in the coronary sinus and duodecapolar in the right atrium. And this is the initial EGM. We have the PP interval of 279 milliseconds. So following this mapping, for this case, we used 3D mapping. So the right atrium was mapped. Due to technical difficulties, I couldn't upload the images, so I apologize for that. However, the mapping showed that the entire tachycardia cycle length was not observed in the right atrium, and it was suggestive of a tachycardia originating from the left atrial side. So as a result of that, following this, we went ahead to do a transeptal puncture. And after transeptal puncture, because he had a previous RFCA for atrial fibrillation done, we assessed the pulmonary veins for potential, and all 4 pulmonary veins using the octa-ray catheter were clean of potential. Then we proceeded to do coherent mapping, which shows the LA activation pattern that's on the left. And this showed, sorry. Yeah, so this showed an area of slow conduction around the anterior line of the left atrium. And additionally, we see over here what looks like some scar tissue here and here. So from this, we hypothesized that the previous radiofrequency catheter ablation included pulmonary vein isolation and possible generation of an anterior line. And that is likely responsible for this area of slow conduction. So to summarize everything so far, a 60-year-old male who had radiofrequency catheter ablation for atrial fibrillation 17 years ago reported with palpitations, and the right atrial activation mapping did not cover the entire cycle length of the tachycardia. All four pulmonary veins were clean of potential, and coherent mapping suggested slow conduction in the region of the anterior line. So at this point, a diagnosis of a left atrial anterior line dependent reentrant tachycardia was made. And so we proceeded with the ablation. This is the RAO view. The LAO view accidentally got deleted. I apologize for that. But this is the placement of the ablation catheter. And upon ablation of the anterior line, we see here the atrial flutter terminating at this point after generation of sufficient block of the anterior left atrial anterior line. We proceeded to assess the CTI, and it showed block. Here we see evidence of the clockwise CTI block and anti-clockwise CTI block, suggesting that there was bidirectional block of the CTI. So to compare pre and post ablation images, we see here this is pre-ablation with marking of the ablation line, and then this is post-ablation after the actual ablation had been done. We see the difference in the activation patterns. And after the ablation, this is the final EGM that was obtained, showing that the patient was in sinus rhythm. And this is the ECG after the procedure, showing resolution of the atrial flutter and restoration of sinus rhythm, here at a rate of about 60 beats per minute. Thank you.
Any question, comment about this case, gentlemen? No one has a question, all clear? Kofi, let me ask you this question now. If someone had ablation 17 years ago, you don't know where the line of blocks are. When you look at your right atrial EGM alone, can you tell me that 100% sure tachycardia circuit is not right atrium? Yes or no?
Sorry, I didn't get the question.
The question is, if somebody had a catheter ablation 17 years ago, you don't know where they ablated, patient in atrial flutter, and then I can see patient with a huge biatrial enlargement, but then you're looking at the intracardiac EGM baseline, right atrial activation alone, and left atrial activation alone. Can you state that your tachycardia circuit is not right atrium? Yes or no? Think about it.
I'm not sure.
You're not sure? Okay.
No.
So especially people who has a May surgery, many linear lesions, until you entrain, just looking at the one single catheter loop of a right atrium, I don't care whether you circle entire right atrium, you cannot state that tachycardia not coming from the right atrium. So you do need to do additional to that pacing maneuver, entrainment. Make sure there is no progressive fusion, entrainment, conceal, so on. It is an important concept. Perhaps when you have some new patients who never had ablation, heart size is smaller, You may argue that comment, but not into such a big heart. That's the reason you guys put a two catheter, I assume, because you got one duodeca in the right atrium, and then coronary sinus another decapolar or 22 duodeca out there. So I think that's an important concept. So for fellows, for your standard approach for this kind of case is when you put a diagnostic catheter, do intermittent pacing as well. Make sure that the right left differences and so on. That'll give you a lot more information and also confidence that which side you're dealing with. Okay?
Okay, thank you.
Next question I have, show me the tracing. You have a sign of rhythm ECG. Now your tachycardia ECG, very first one, right?
Yes.
What you can tell me more about this ECG?
Okay, so in this ECG, as I mentioned earlier, the rhythm is irregular, and then there are P waves at a rate of about 250 beats per minute. There's an incomplete right bundle branch block as well. We see the RSR morphology in V1, and the QRS is narrow. The T waves are quite peaked in V2 to probably V4, maybe V5. But given that his electrolytes were fine, I'm not sure if this has significance for this patient.
Okay. So if you have a atrial flutter, why is it irregular? QRS complex.
Because sometimes in atrial flutter there can be a variable AV conduction, so
Okay.
that can account for irregularity in the QRS.
If that's the case, where is the block?
Pardon?
Where is the conduction delay, conduction slow you're talking? In other words, if it was an AV node, would you do that?
Yes, it would be an AV nodal delay, like AV nodal blocking conduction.
Well, you already have a 2-to-1 block and AV node going on. Your intracardiac shows a time to time 3-to-1 block, 2-to-1 block. Is that all AV node contribution, you think? Take a look carefully your PR interval. One flutter wave before the QRS complex. B1. Go to B1.
V1. Okay.
That's
Yeah.
the next QRS. No, next one. Follow.
Next one. Okay.
Longer. Next one.
Yes.
Longer. And then there's another P. And then got shorter. What does that mean?
It means it's Wenke backing.
Wenke back. Okay. So this is important concept. If you have a regular reentrant tachycardia, rate stable, flutter always going to conduct 2-to-1, 4-to-1, 6-to-1, 8-to-1, so on. It's a mathematic, okay? When you have such variation of conduction, you also need to think about whether there's a two level of block. One is an AV node. You just mentioned patient of right bundle branch block morphology. Maybe there is a intra common conduction tissue block as well. So we used to teach this to the fellows. When you see flutter with Wenke-Bach behavior, typically two level of block, not just AV node. There's another one below. Could it be a functional? Could it be rate dependent? Because, or could it be what the Josephson text would describe what? Gap phenomenon. There's a 7 type of gap, right? Remember? I want you to go to home and study gap phenomenon. Okay?
Okay.
Is an important concept in EP. So there's a concealment phenomenon, transductor activation concealment, so many things can happen here. So that was the reason probably this is atrial is irregular. Okay? All right, go to next. Chest X-ray. What is unusual about this X-ray and your catheter? This guy has a very slender, long heart. And then during the procedure, you have to put a 2 dodeca catheter to cover all the atrium. Did that make sense? Did you look at your map, Kofi?
Pardon?
Did you look at your 3D mapping? How the left atrium shape looked like?
Yes.
pretty big at left atrium. Is this chest X-ray looks at left atrium enlargement?
No, it doesn't.
I want you to check this piece. It may not be the same patient's X-ray. Okay?
Okay.
Look at the left bronchi. It's just straight down. It's normal left atrium. This chest X-ray. And the right atrium is not even bulging. I'm a little bit concerned, curious about this X-ray. When you showed me, I said, wow. And then I got shocked because you put your catheter, and then wow, you got such a gigantic right atrium and left atrium. How the X-ray look like that way? So double check, please.
Okay, I will.
Great. Keep going. So echo is normal. The normal, okay. Keep going. Okay. Now take a look at this. So you got duodeca covered in the right atrium, and then you got that kind of CS anteriorly, right?
Yes.
So is that you notice any particular reason to this because of you are suspecting something, or usually you guys put only one duodeca catheter in this size of heart? Am I right? Any particular reason did you use it?
So the catheter in the coronary sinus is a decapolar.
I understand, but you pushed all the way out to the front, anterior cardiac vein, right? Your
Yes.
catheter in cardiac vein is not in the CS.
Okay.
Okay. What is the anatomic definition of coronary sinus? Until where we call coronary sinus, after that call what?
Until it bifurcates into the great cardiac and then the middle cardiac veins.
Which is the middle cardiac vein you're talking? Okay. Kofi, coronary sinus has two valves. One valve called Tavesian valve at the os, right?
Yes.
And then second valve where is?
That's the valve of Vicens.
Vicens valve. So between the Tavesian and Vicens is a coronary sinus. The other Vicens valve is a cardiac vein, great cardiac vein. Okay?
Okay.
So your catheter is in great cardiac vein. So we need to describe it in the right terminology.
Okay.
That's where you are. Okay? Now, if you've had such trouble putting such big catheters, is that his bundle you did not put it any reason? Is it his bundle is not important here, you think? It is very important, especially when you're doing redo case, because you want to know where the septum is in relation to the two atrium, especially his bundle region. So you want to look at the atrial EGM in that area. Then also you could have tell you whether it's a right or left atrium easier. Okay?
Okay.
Because whoever attending doesn't do that does not mean it's the right thing. You always have to think through what you're going to do in your country. Okay?
Okay.
So think about it when you have your country no 3D, you got to do such a case. You're going to need a lot more help than this to figure out. Okay?
Okay.
All right. Keep going. Okay, so look at the EGM. What is the characteristic about the EGM? Remember, your CS cat is way up, okay, in the cardiac vein. CS 910, HRA 1314, maybe even 1718. Is it much a different timing? Do you see any difference? I'm asking.
18.
Yeah, earliest CSA is, it looks like, whatever, it's 910. And then you got also far field signal, and then so on. So I don't know where you draw the line there, but I'm not sure that lines are correct. If you go to the second line, when you draw there, looks like a 13, 14 and CS, it looks like almost same time. And I think H 1920 is noisy. I can't tell 100% sure what date it is. So what did they mean?
So this was measuring the PP interval using H1920 as the reference.
Okay. So 1920 is what? Where your catheter was in septum, correct?
H1920 is within
Septum.
that's yes, it's
Yes.
around the
Yes.
interatrial septum.
Yes. And then you have a 13, 14 is about the same timing. 13, 14 and proximal CS.
13,
Almost,
14.
right? Yes, and the proximal CS.
H
Right
13,
there.
14 is around here.
How about the CS 9, 10?
So CS 910 will be much higher up, somewhere
Keep coming.
here.
Yeah, there he is. So what is
Yes.
that? So you have an subtle electrode earlier, and 13 and 8 right atrium lateral wall, and CS lateral wall is about the same time. They tell you what? Tachycardia is in between two, right?
Okay.
The subtle tachycardia that you already could have told looking at the EGM. Then you do entrainment from there to confirm your answer. Okay?
Okay.
Right. So interpretation of EGM always has to be relation to the catheter position. Okay? Because we all always put a catheter differently. Okay, let's go next. Any issue with the transsubtal here in particular?
No, there were no
Good.
issues.
Now, did you do single transsubtal or double transsubtal?
Single transseptal.
Okay. If you were doing this case in your country, would you do single or double?
Double.
Double. Agree. Good answer. Okay, let's go. So take a look at this propagation map. What do you think? Kick on. Rotate some more. I think they need to appreciate this a little bit better. Yeah, keep playing again. So is left side of the passive activation. We agree. Okay. But then look at where the wavefront colliding in the posterior wall of a right palmar vein. Take a look. Play again. So is this patient PV was checked during the procedure? Do you remember? Right palmar vein was no connection?
As far as I can remember, there wasn't.
Because of this, conduction to the carina looks very suspicious to me. If you look at the carina conductions, if they're slow and gradually going into the palmar vein. You see them?
Yes.
Yeah. You want to make sure that when you see this pattern of activation of palmar vein through the isthmus, check the PV, please. PVOS. Okay?
Okay.
It'd be a timing issue with the 3D mapper, but I think I would definitely recheck it. Okay?
Okay.
Because the reason I ask you this question, nobody goes to the sinus rim to the HR flutter unless you have a trigger. And I haven't heard that you guys ablate the trigger. So this is something that you need to keep in mind. So that's always double check, please. Okay, keep going. Okay, that's good. All right. That was a clean. That's good. Okay. So you ablated. All right. Now you show me the ablation, after ablation signal there. I think you had the one tracing termination there. So here your tachycardia terminated by what? Same activation sequence and gradually fluctuates the cycle lengths and then terminate. Okay?
Okay.
Not terminated by the PAC. It's important to know that. If your tachycardia terminated by PAC, there may not be ablation effect. Could be PAC critical time due to tachycardia circuit termination. All right? So it's important to see how terminate. It's a good job. Okay, next. Okay, pacing, conduction, block, and floater isthmus. Yeah, good. Keep going. Okay, good. Okay, that's remap. Okay, keep going. Okay, right here, just for a second here. This is a catheter, ablation catheter banging something. I don't know. I can tell what it is.
No, it's just noise. I should have deleted it from the slide. I apologize for that. For the ablation catheter, it's just noise. I should have deleted it from the slide. I apologize for that.
Yeah, I understand that. But I want to know What are you recording in the CS78? 3, 4. No, right after first. Go back to first. Yeah, there. You got, and then there's another potential right behind it. Go to the right a little bit. Yeah, right there. Is that an artifact? Or that's a PAC?
Think it may be artifact.
You think so? Because you have all CS channels. 9, 10 to 1, 2. You disagree with that or no? An activation sequence is CS proximal to the distal, or almost seem like a double potential there. And then I don't know. There's no such other signal at the last complex. CS is gone now there. I don't know whether you're removing CS catheter during this time. I don't know what you're doing. Yeah, I want you to go take a look at that signal. Okay? Because that's not a PEC trigger you're looking for. It is quite common after termination of HR flutter. You need to give isopro challenge all that to see whether there's any consistent firing from APC. If you do, you need to go after. Get rid of that. Otherwise, this patient will come back with another flutter. That is our experience. Okay?
Okay.
Great. Okay. Anyone else has any comment, please? No comment, no questions? All right. You guys have perfect time. You got 6 more minutes, but then good, wonderful job. Good. So keep it up. Keep reading. Okay, Kofi?
Okay. Thank you very much.
Fine. Okay. All right. I gotta go sleep now. So have a good night. Okay.
All right.
Bye-bye.